Alrighty, everyone, I'm going to go ahead and get started. So my grill presentation today is going to be on the use of empiric or early antifungal use in the ICU. For those of you who I haven't met yet, I'm Ravi, one of the ID residents. I'd like to give a big thank you to Brian Buss for all of his help and support in preparation of this grill. Now we're going to go over the overarching purpose for this presentation. So the question that we want to answer at the end of this presentation is, which patient populations in the ICU are at the highest risk of invasive candidiasis and would warrant the use of early antifungal therapy? The objectives associated with this purpose statement. So first, we want to address the surviving sepsis 2021 guideline update. Next, we would want to describe the epidemiology, pathophysiology, diagnosis, and treatment options for invasive candidiasis in critically ill patients. Next, we want to discuss recent primary literature regarding the use of early antifungals in critically ill patients. And then finally, we want to determine the value of non-culture adjuncts in conjunction with clinical prediction scores to better assess at-risk patient populations. Now to address the elephant in the room, I'm sure you all are familiar with the surviving sepsis guideline update this past fall. So I would like to address the recommendations for the initiation of antifungal therapy. So the surviving sepsis guidelines say for adults with sepsis or septic shock at high risk of fungal infection, we suggest using empiric antifungal therapy over no antifungal therapy. This is a weak recommendation and low quality of evidence. So the first question that comes to mind is, what patient populations are these that are at the highest risk of fungal infection? So I would like to introduce the 2016 IDSA guidelines for the management of candidiasis. So this will be the basis for the bulk of the recommendations and the risk factors that are associated with invasive candidiasis. So here on this slide are the risk factors for invasive candidiasis. So here on the left, we have risk factors that apply to all patients, and then on the right, there are additional risk factors that are associated with immunocompromised patients. So for the sake of this presentation, I will be focusing on the immunocompetent or non-neutropenic host. So detouring back to the surviving sepsis guideline. So this table, which highlights the risk factors for Candida sepsis, is transposed directly from the guideline as they highlight the risk factors that are associated with Candida sepsis. So I'd like to highlight how many of these risk factors would apply to the majority of the ICU population. So first, neutropenia is a very non-specific risk factor, which could apply to the majority of ICU patients. Immunosuppression, so this can be associated with patients with controlled rheumatoid arthritis, or asthma, COPD as well. Patients who typically present to the ICU are very acutely ill, can have a high Apache 2 score. They can also have long ICU length of stay. They can also have the presence of a central venous catheter or other intravascular devices. And as we all know, patients, whenever they're admitted to the hospital, they're acutely ill, they are placed on broad spectrum antibiotics. Patients can present needing an emergent laparoscopic appendectomy or other hepatobiliary procedures that can predispose them. Patients can present with an acute kidney injury, or they can be dependent on hemodialysis. And they can also have a history of prior surgery. So would we empirically start microfunction on all of these patients? Something doesn't seem right here. So now, before we move on to my first clinical question, would like to briefly discuss invasive candidiasis, the disease state itself, and with a focus on how challenging it is to diagnose and manage these patients. So here on this slide goes and shows that invasive candidiasis encompasses candidemia and deep-seated candidiasis, which are infections of tissue sites beneath mucosal surfaces. Deep-seated candidiasis may stem from hematogenous dissemination or direct introduction of Candida to a sterile site. So deep-seated infections may remain localized, or they may spread to contiguous sites or lead to secondary candidemia. So in diagnosing invasive candidiasis, there are three different entities that need to be considered. So on the left, you have candidemia in the absence of deep-seated candidiasis. In the middle is candidemia and deep-seated candidiasis. And then all the way on the right, we have deep-seated candidiasis. So examples of deep-seated candidiasis in the absence of candidemia would be intra-abdominal abscesses, peritonitis, osteomyelitis, and/or endocarditis. Now moving on to the epidemiology of invasive candidiasis. So candidemia is the fourth most common cause of hospital-acquired bloodstream infections in the United States, estimated about 25,000 cases per year. There's a high cost burden to institutions and healthcare systems across the country, costs approximately $40,000 per patient in the United States. Looking at the incidence rate of invasive candidiasis, it's approximately 3 to 7% in the ICU, associated with a high ICU mortality rate of anywhere from 30 to 40%. And mortality is associated with older age, higher Apache 2 scores, the particular species of Candida that are causing the infection, immunosuppression, renal impairment, and prior antifungal use. Now moving on to what are the actual species of Candida that cause invasive candidiasis. So greater than 95% of invasive candidiasis are caused by 5 different species. The most common would be Candida albicans. Next would be Candida glabrata, following by Candida parapsilosis, Candida tropicalis, and Candida krusei. The remaining 3 to 5% are caused by 12 to 14 different species. So Candida here on the right, there's a morphology of Candida seen on the gram stain. So it's essentially a yeast. It can propagate by budding out from similar cells from their surface, and the elongation that you see here from the parent cells can produce a chain, which is called a pseudohyphae. Here on this slide is a chromoger Candida. So point of emphasis here on this slide is that it grows readily on culture. So this is a culture medium that is claimed to facilitate isolation and presumptive identification of clinically important yeast species. So there's a chromogen mix that's a part of the medium, which release different colored compounds upon degradation of specific enzymes caused by each of these species. As you can see, it leads to different colors being on the medium to help identify. This has high rates of sensitivity and specificity. Now moving on to pathophysiology of invasive candidiasis. So Candida species can be detected on the mucosal surfaces of approximately 50 to 70% of healthy humans. And when you have breaches in the intestinal barriers, so that can occur anytime after GI surgery, Candida can disseminate to the abdominal cavity directly and invade the bloodstream. Under normal conditions, the fungus behaves as a commensal organism without causing disease. So then impairment of your immune response, such as an immunocompromised host, among other factors, can lead to fungal overgrowth in the gut and candidemia, which can progress on to deep-seated candidemia. So this can manifest as endocarditis and other deep-seated infections. So how do we diagnose patients with invasive candidiasis? So the gold standard for diagnosing is positive cultures from sterile sites. So these can be blood, peritoneal fluid, or pleural fluid. However, there are a number of limitations associated with blood cultures. The overall sensitivity for invasive candidiasis is approximately 50% from blood cultures. There's a common misnomer that blood cultures miss 50% of invasive candidiasis diagnosis, but this is a misnomer. So blood cultures will not diagnose deep-seated candidiasis that is not associated with candidemia. So if you do not have candidemia in your bloodstream, that doesn't mean that you don't have deep-seated candidiasis. So as a result of this, non-culture diagnostics may help identify cases that are missed by blood cultures, by detecting components of Candida that are remnants from prior candidemia or released from infected tissue sites. And also the time to positivity is also species dependent. So typically it causes time to positivity in blood cultures is approximately 96 hours. The greatest time to positivity, Candida glabrata grows the fastest, followed by Candida albicans, then followed by Candida parapsilosis. Now moving on to rapid identification. So I will briefly discuss ways that are available in the market for how to rapidly identify these organisms. So first you have the BioFire fulminary multiplex PCR. So this is the BSID2 identification. This is how Candida is identified at Meritor. So it requires a positive blood culture and it includes the most commonly isolated Candida species. Next is going to be the T2 Candida PCR. This is a very expensive, novel way of delineating Candida species. It also requires the use of blood cultures. Next is MALDI-TOF mass spectrometry. So that is how we identify Candida species here at UW. So it uses lasers to ionize biochemicals that can be detected and measured based on their mass to charge ratio. And again, this requires growth from pure culture. So the main takeaway from this slide is that all of these require positive cultures. So again, the same sensitivity that I had mentioned on the previous slide still applies to these as well. Now moving on to non-culture diagnostics. So this is the detection of fungal DNA, RNA, or gene products in clinical material. So I'm going to be talking about Fungitel or the 1,3-beta-glucan assay. So this is a cell wall constituent that can be detected in the serum for Candida species, Aspergillus, Pneumocystis, Eurovici, and Fusarium species. So it has the greatest amount of sensitivity for Pneumocystis. It does not detect Mucor, Cryptococcus species, and a particular species of Blastomyces. So this can theoretically identify cases of invasive candidiasis prior to positive blood cultures to ideally shorten time to initiation of antifungal therapy. So here at the bottom, we have a table as to the performance of 1,3-beta-glucan. So this is from pooled sensitivity and specificity in patients from 17 different cohort studies with proven or probable invasive candidiasis and consecutive repeated tests. As you can see, it has similar sensitivity and specificity of approximately 75 to 80%. So you may be thinking, what is probable or proven invasive candidiasis? So the EORTC and the MSG ERC is a renowned global society filled with mycologists that work to define invasive fungal infections in a variety of immunocompromised patients and in immunocompetent patients as well. So again, as I mentioned, the diagnosis of invasive candidiasis is very difficult, presents a lot of challenges. So they work together and they released this update in 2021. So here is the criteria for proven invasive candidiasis. So that involves the definitive evidence of the organism in a normally sterile site. So it includes at least one of the following. So a tissue sample from a normally sterile site obtained by needle aspiration or biopsy. So this can be done in the OR, and then would want to extract Candida species. And then you would want to recover that Candida species by culture of a specimen obtained by a sterile procedure, which is also consistent with the clinical picture as well as with imaging and or having positive blood cultures. Now moving on to the definition of probable invasive candidiasis. So that includes the presence of at least one clinical criterion. So that is going to be ocular, CT, clinical or radiological abnormalities, plus the presence of at least one mycological criteria. So that can include anything from positive beta-glucan, recovery of Candida from an intra-abdominal specimen obtained either surgically or less than 24 hours from an external drainage, and at least one host factor, which would include corticosteroid use. So that's the equivalent of prednisone 20 milligrams daily, neutropenic patients, so ANC less than 500, patients who have impaired gut wall integrity, impaired cutaneous barriers to bloodstream infection, previous colonization with Canada, and then, of course, our stem cell transplant and our solid organ transplant patients. Now I'm going to be reintroducing the 2016 IDSA guidelines again for invasive candidiasis. I would just like to emphasize that the guidelines revolve around two key principles. The first being source control. So they recommend to remove all central venous catheters as early as possible, as safely as possible. And also, if it's appropriate, to instill drains and to do debridement if it's appropriate. And the next principle revolves around the early initiation of antifungals, ideally within 24 hours. The longer you wait past that 24-hour mark, it's been associated with high mortality rates of almost 50%. The guidelines also recommend different treatment strategies. So this is also going to be important as to when we get into the primary literature to delineate between these different treatment strategies. So for prophylaxis, these patients are at high risk of invasive fungal infection, so they are going to include the patients that I mentioned earlier with the risk factors for candidiasis. They don't have any typical signs or symptoms. For preemptive therapy, so this is going to be a positive fungal non-culture adjunctive test or radiological evidence. So this would be patients who have a positive beta-glucan. For empiric treatment, so this is going to be an established clinical signs and symptoms of infection, and then targeted would be our culture-directed therapy. So here is a nice algorithm which shows how do we manage or treat patients for invasive candidiasis. So starting from the top, when Candida has been detected, the first line agent is going to be an echinocandin. And as you can see, that applies for all 5 of the most common species of Candida. The preferred initial therapy is, again, echinocandin. And the next, for preferred step down, azoles are recommended. So kind of going into how did that become the basis of the recommendations. So there have been approximately 10 randomized trials that have looked at the outcome for patients with invasive candidiasis treated with various antifungals. These have been very similarly designed trials. They've been non-inferiority trials. They've had similar inclusion and exclusion criteria, and they've exhausted each possible drug class combination. So they've looked at comparing amphotericin B versus your common azoles, such as fluconazole, voriconazole, versus echinocandins, and they've exhausted all of the different drug class combinations. And the outcomes of these trials have shown that superiority for echinocandins have not been seen on an individual trial basis. However, our own Dave Andes performed a patient-level systematic review of randomized trials for candidemia and invasive candidiasis. So he pooled data from approximately 2,000 patients from 7 different randomized trials. So he wanted to address the impact of host, organism, and treatment-related factors on mortality and clinical cure for candidemia and invasive candidiasis. So the following baseline characteristics were seen for those patients. So they were of relatively old age, 55 years old, predominantly male. They were acutely ill with a high Apache score of almost 15. Almost 80% of these patients had a central venous catheter at enrollment, and the breakdown as to what the Candida species that was isolated is listed there as well. So the outcome that he wanted to look at was 30-day all-cause mortality, which he ended up finding that across 2,000 patients from 7 trials, the 30-day all-cause mortality was 31.4%. So this is in line with the epidemiology of invasive candidiasis that I had mentioned earlier, that approximately 30 to 40% of these ICU patients have grave outcomes. Here are the results of that trial. So to focus on echinocandins, so echinocandins treatment was associated with reduced mortality, as you can see here, by the odds ratio. And then also removal of central venous catheter was associated with reduced mortality as well anytime during treatment. Increasing age, greater Apache 2 scores, the use of immunosuppressive therapy, as well as infections caused by Candida tropicalis was also associated with a higher mortality. Another aspect that he looked at was the use of echinocandin treatment. So there was a significantly improved survival seen. So the mortality rates in these patients was 27% and had greater clinical success in comparison to treatment with an amphotericin B formulation, where the mortality rate was seen to be 35%, or azoles, where it was seen to be 36%. And this was statistically significant. So this is the basis for our initial therapy for invasive candidiasis. Now moving on to the role of azoles, which have been defined as a reasonable option for step-down therapy. So there have been a number of recent open-label non-comparative studies which have looked at early step-down from an echinocandin to oral azole, either fluconazole or voriconazole after 3 to 7 days. They have found that there's no difference in efficacy, and it's been well tolerated in the management of candidemia or candidiasis. So the conclusion from that, either a step down to oral fluconazole or voriconazole in clinically stable patients with a susceptible organism following successful induction with an echinocandin is a reasonable role as step-down therapy. So this will take us to our first question. So among non-neutropenic, critically ill patients, which patient populations are at the highest risk for invasive candidiasis in the ICU and would warrant empirical antifungal therapy? Now we will be going into the primary literature. We're going to be looking closely at randomized trials focusing in on different high-risk patient populations and whether the use of prophylactic or preemptive use of antifungals provided benefit in the rates of invasive candidiasis and or mortality. So the first trial looked at echinocandin prophylaxis using a validated clinical prediction rule. So this was a study performed by Ostrowski, Zeichner, and colleagues. This was a multi-center randomized double-blind placebo-controlled trial where they screened approximately 16,000 patients. So the purpose of this study was to assess caspofungin prophylaxis using a clinical prediction rule to better identify at-risk ICU patients. So the prediction rule looked at if patients were at the ICU for at least 3 days, they were mechanically ventilated, they were exposed to broad spectrum antibiotics, they had a central venous catheter, and they had one of the following characteristics as well. They had TPN, were receiving a renal replacement therapy, had major surgery, pancreatitis, steroids, or immunosuppression. So the intervention that they wanted to look at was caspofungin versus placebo for the duration of the ICU stay. So the outcome was the incidence of invasive candidiasis less than 7 days after ending prophylaxis. So the results of this study, so here on the left is going to be the cumulative incidence of invasive candidiasis. So that's going to include proven or probable invasive candidiasis. As you can see that there was a lower amount of patients who had the incidence of candidiasis 9.8 versus 16.7% in the placebo group. However, this was not statistically significant. Moving on to proven invasive candidiasis, this was also not statistically significant, but a lower incidence was seen. However, of most notable would be the rates of death. There was actually higher number of patients who experienced death in the prophylaxis group. So what can we take away from this? So the prediction rule worked to better identify at-risk patient populations. As you can see, going to the first bars in the graph, 16.7% of the patients were identified, so it helped to identify a bigger patient population. And again, benefit of caspofungin prophylaxis was not seen. Now we're going to be moving on to the use of preemptive echinocandin status post GI surgery. So this was going to be a study that was performed by Nitsch and colleagues. This was an exploratory randomized double-blind placebo-controlled trial, which included 271 ICU GI patients that were screened. So these were patients who were emergently admitted to the hospital to have emergent procedures that were performed. So moving on to the purpose of this study, they wanted to assess the use of preemptive microfungin therapy in postoperative GI patients with an expected ICU stay of at least 2 days. So the predictions rule that they looked at here included a community-acquired infection or a nosocomial-acquired infection, intra-abdominal infection requiring surgery and ICU stay, as well as appearing in the ICU less than 48 hours or in between 72 to 120 hours for community-acquired infections. So the intervention that they looked at was micafungin versus placebo for 6 weeks up until death or until patients achieve enteral feeding for approximately 50% of their caloric requirements. So again, the outcome that they looked at was the incidence of invasive candidiasis at the end of treatment. Again, so in this graph, you have micafungin versus placebo. There is actually a non-significant difference between the use of preemptive micafungin at 11.1% versus placebo 8.9%. This is not significant. And again, preemptive use was associated with a higher rate of mortality. So again, the takeaway from this is that there were no improvements that were seen in the rates of invasive candidiasis or in mortality with preemptive micafungin therapy. Now we will be looking at the use of empiric azole therapy in higher risk patients. So these are going to be patients that we think of as our classic septic shock patients. This was a study performed by Schuster and colleagues, which was a double-blind placebo-controlled randomized trial performed across 26 ICUs in the United States. So the purpose of this study was to assess whether there is benefit in empiric fluconazole therapy in septic ICU patients. So the prediction school rule that they looked at was patients who were febrile for 4 days while receiving broad spectrum antibiotics for at least 4 out of the last 6 days, had the presence of a central venous catheter, had a prolonged ICU stay of at least 4 days, and their Apache 2 score was at least 16. The intervention was conazole, 800 milligrams daily for 2 weeks, followed by, and the patients were followed thereafter for 4 weeks, and that was versus a matching placebo. And here in this outcome that they looked at was a composite outcome, resolution of fever, absence of invasive fungal infection, and then no discontinuation of therapy due to toxicity and no need for a non-study antifungal agent. Again, in the composite outcome, there was no difference in the rate of invasive candidiasis at 36% versus 38%. Again, not statistically significant. In the rates of invasive candidiasis, there was again no real difference, 5% versus 9% with a p-value of 0.24. Again, empirical therapy was associated with higher rates of mortality. Again, what is the main takeaway from this? There is no improvement in composite outcomes, rates of invasive candidiasis, or in mortality with fluconazole prophylaxis. Now we will be moving into the Empiricus study, which looked at ICU patients presenting with septic shock. This was conducted by Timsit and colleagues. This was a multi-center randomized double-blind parallel group study conducted across almost 20 different ICUs in France over a 3-year period. So they wanted to look at the benefit in empiric micafungin use in septic ICU patients, whilst also taking into consideration the role of being previously colonized with Canada. So this was a new twist to these studies, since the previous studies had not taken into consideration whether patients were colonized. So the prediction rule that they looked at was being mechanically ventilated for at least 5 days, having at least one positive colonization site for Canada, and having at least one additional organ dysfunction, previously being treated for at least 4 days with broad spectrum antibiotics in the last 7 days, presence of a central venous catheter, and then a new finding of ICU-acquired sepsis. The intervention was micafungin, 100 milligrams daily for 14 days versus the matching placebo. And the outcome they wanted to look at was day 28 survival without proven invasive fungal infection. So here are the results of this study. So of note, they did end up finding a statistically significant difference in the new invasive fungal infection at day 28, 3% versus 12%, but I will be talking about that in a little bit. But in terms of the day 28 survival without invasive fungal infection, this was found to have a non-statistical difference between the two groups. And in terms of the survival, there was also not a difference there. So the main takeaways from this study is that there was no true benefit seen in prophylaxis. I had mentioned that there was a difference in new invasive fungal infection at day 28 between micafungin versus placebo. However, the fragility index at day 28 was 3. So that would mean that if there were 3 additional patients in the group, then that means that it would have rendered the value to be statistically non-significant. And then in patients who actually did develop invasive candidiasis, more patients died in the prophylaxis group, 25% versus 20%. So here, let's summarize all the different studies. So the first study we talked about looked at the use of prophylactic caspofungin in high-risk ICU patients using a validated clinical prediction rule. Did we see benefit with early antifungal therapy in terms of the rates of invasive candidiasis or death? No, we did not. Next, we looked at a study using preemptive micafungin in postoperative GI ICU patients. Was there a benefit seen in terms of invasive candidiasis rates or death? No, there was not. Next, we looked at the use of empiric fluconazole in septic ICU patients. We also did not see a benefit there. And then also in empiric micafungin use in our traditionally septic ICU patients previously colonized with Candida, did we see a benefit there? No. So again, what does all of this mean? So the takeaways from this is that evidence does not support the use of prophylactic antifungals in non-neutropenic critically ill patients. Again, we still are seeing the high rates of mortality due to invasive candidiasis. So there's a need for non-culture diagnostic tools to help elucidate the risk in the highest risk patients. So this takes me to my next clinical question. So what are the benefits and risks associated with using non-culture adjuncts and clinical prediction scores to aid in this identification of these high-risk patients for invasive candidiasis? So the first score we'll be looking at is called the Candida score. So this has been studied by Leon and colleagues in a cohort of 31,000 patients where they took into consideration and used different point values for patients who were exposed to TPN, surgery, having severe sepsis, which resulted in a point of 2, and also being colonized with Candida. So the threshold for this score is 2.5, so greater than 3 would be a positive Candida score. And what they ended up finding was that, of note, is that it had low positive predictive value of 16%, but its use would be for negative predictive value, which they found to have a value of 98%. Next, I'm going to be talking about the Ostrowski's-Leichner clinical prediction rule. So the first study, which we discussed, the use of caspofungin prophylaxis in high-risk patients, they used this score, and this is the validated score, which had a component of major criteria as well as minor criteria. So in terms of the major criteria, they would have to have the presence of being mechanically ventilated for at least 2 days and systemic antibiotic use, as well as the presence of a central venous catheter on any day 1 through 3 of ICU admission. The minor criteria that they would need to have is any major surgery in the 7 days preceding ICU admission, pancreatitis in the 7 days before ICU admission, use of steroids and any other immunosuppressive agents, use of TPN and or use of dialysis. Again, similar findings to the Candida score, not much use for positive predictive value. That's only about 10%. but its benefit would be from negative predictive value, which has been seen to have at 97%. Now I'm going to be talking about 1,3-beta-D-glucan. So here's a nice visualization of the fungal cell wall. This is the most abundant polysaccharide contained in the cell wall of most fungi. So this is a pan-fungal biomarker for various infections. So now we're going to be assessing the use of 1,3-beta-D-glucan. So again, as I had mentioned earlier, there's a theoretical benefit of the use of this biomarker. So this can potentially lead to early initiation of antifungal therapy. A positive value is here on the right, is greater than 80 picograms per milliliter, and then less than 80, indeterminate or negative. However, there's a number of limitations that are associated with 1,3-beta-D-glucan. There are a number of false positive tests, so this can result from systemic infections, such as gram-positive, particularly Streptococcus species, and gram-negative bacteremia when it's affected by Pseudomonas. Patients who are on dialysis with cellulose-containing filters have also been associated with false positive anti-neoplastic treatments, such as polysaccharide K, administration of IVIG, albumin, or coagulation factors, and or surgical sponges in gauze products. Another limitation is that it has highly variable sensitivity and specificity. As I had mentioned earlier, specificity and positive predictive value can be increased by 2 consecutive tests, and this was validated in a 2013 study by Fangino and colleagues in high-risk intra-abdominal infections, where they found that 2 consecutive tests could lead to improved specificity and positive predictive value. And also, the use of higher cutoffs for positive 1,3-beta-glucan values have also been suggested. So we see here on the right, a positive value would consist of a score of greater than 80. So higher cutoffs such as 250 have been considered, which leads us to our next study. So this is looking at the use of a biomarker performance in invasive candidiasis in ICU patients. So this was done by Dupuy and colleagues earlier last year. And this was a pre-planned ancillary analysis of the Empiric study. So this was the study I had mentioned by Timsit and colleagues. So the purpose of this study was to assess the prognostic value of beta-D-glucan of greater than 80 cutoff and repeated measurements of beta-D-glucan. So again, to remind everyone, the patient population was immunocompetent critically ill patients with ICU-acquired sepsis. They had multiple previous colonization with Candida and multi-organ failure who were also exposed to broad-spectrum antibiotics. And the outcome was the incidence of suspected invasive candidiasis. So what did they end up finding? They ended up finding that beta-glucan of greater than 80 at inclusion was more predictive in predicting invasive candidiasis as a hazard ratio of 4.67. This is found to be statistically significant. However, a beta-glucan score of greater than 250 did not result in any improved benefit. They ended up finding that invasive candidiasis using the beta-glucan of greater than 80 is associated with a negative predictive value of 96%, which is in line with what previous studies have shown. So what can we conclude from this? First, is strongly associated with the occurrence of invasive candidiasis. Higher beta-glucan values do not have any added benefit in these patient populations. So these are critically ill septic patients, and then high negative predictive value for beta-glucan of greater than 80. So here is a table that nicely summarizes the recommendations for the use of beta-glucan in different patient populations. So again, we're going to be focusing in on ICU patients. So we look at the third column is the negative beta-D-glucan to exclude invasive fungal infection. So if patient has a negative value, this can be used if the pretest probability of candidiasis is estimated to be low or moderate. Next, we'll be talking about positive beta-glucan to start antifungal therapy for probable IFI. So this would be restricted to high-risk patients So what are these high-risk patients? So these are going to be patients with complicated abdominal surgery. So this would include a GI perf, anesthetic leakage, having a diagnosis of necrotizing pancreatitis or a Candida score of greater than 3, and they recommend 2 consecutive positive values here. So to recap this presentation, so there are a number of non-specific risk factors that can lead to invasive candidiasis in the ICU. The overall clinical presentation and past medical history, such as previous colonization with Canada, is important to assess the risk for invasive candidiasis. It's again very difficult to diagnose. We want to be able to culture it, but we can't always do so. So we have to use the non-culture adjuncts such as beta-glucan and other clinical prediction scores as surrogates to help us assess risk. Um, Non-culture adjuncts and clinical prediction scores have shown negative predictive value in select patient populations. So these are going to be the patients with an increased um, Candida score of 3, having a necrotizing pancreatitis diagnosis. And currently we don't have any tools available to show high positive predictive value. So this will lead to our first knowledge check question. So the performance of 1,3-beta-glucan is analogous to pooled MRSA PCRs in terms of its high negative predictive value. Is that A, false, or B, true? Yes, so the answers are slowly trickling in. Yes, that is true. So pooled MRSA PCRs have been associated with negative predictive value of greater than 90%, which is similar to what we have seen for 1,3-beta-glucan as well. The next knowledge check question is it possible to have candidiasis without positive blood cultures? A, yes. C, I don't know, or shrug. Yes, so the audience is correct. So you can have candidiasis without positive blood cultures. So this goes back to that misnomer that I was referring to. So if you don't have positive blood cultures, that doesn't mean you've ruled out more deep-seated candidiasis, such as abscesses, endocarditis, more deep-seated infections. So yes. And next knowledge check question is, have any trials showed benefit in the use of early antifungal therapy? Yes. B, no. C, SOS Brian Bus. Yes, I agree, Megan. It would be nice to talk this over with Brian always, just to be a little extra sure. But yes, everyone's right. So yes, we haven't had any studies that have showed benefit in the use of early antifungal therapy. So here is a nice little cartoon for everyone's viewing. And with that, I can open that up to any questions that you all may have. Thank you.
Ravi, I'll start. This is Brian. Two-part question. How do you explain the discordance between what the guidelines recommend for empiric therapy, antifungal therapy, and what the studies have shown us as far as prophylaxis, preemptive therapy, and empiric antifungal therapy?
It's a great question, Brian. I think there's a discordance between what the guidelines recommend and in terms of what we've seen in terms of in the primary literature as to whether there is benefit in these different treatment strategies. Um, as we can see that invasive candidiasis is associated with high rates of mortality. It's difficult to diagnose. We see horrible outcomes in patients who are delayed in the initiation of treatment. And that has been a consistent in terms of what we've seen in the literature. And so then we have to use other measures such as these non-culture adjuncts, such as beta-glucan and these other clinical prediction scores to kind of aid in our recommendation or in our conviction to either start therapy or to delay therapy. Um, we have seen that the use is that if you have value, a negative predictive value is strong in a lot of these non-cultural adjuncts. So that would make us feel a lot stronger into what we decide in terms of whether to start preemptive therapy or not. I think what we can all agree on is that invasive candidiasis is like difficult to diagnose and also to manage. I think the guidelines err on the side of caution, and that the only true benefit has been seen in patient populations with Candida score of greater than 3, having necrotizing pancreatitis and/or like an antibiotic leakage in terms of preemptive therapy. But other patient populations, it hasn't been truly validated in.
No, thank you. I agree. But then to lead on that, what is the role of beta-glucan as far as identifying appropriate patients to treat?
So I would essentially view it on the same lines of like MRSA PCRs, in that it helps us to rule out whether we have invasive candidiasis, if depending on whatever the value is. If the value is less than 80, then we can feel essentially convicted with a greater than 90% negative predictive value that we don't have invasive candidiasis. So I would view it kind of analogous to MRSA PCRs.
I agree. And the Dupois study of the TIMSIT study showed that even with a positive predictive value of 17% in probably the highest risk population, those with broad spectrum therapy with central venous catheters in the ICU for 5 days and then developed sepsis in the ICU, it was associated with a positive invasive candidiasis. So like in some cases in the highest risk population, it probably provides some benefit, but overall that sensitivity just isn't high enough in all cases for all patients in the ICU. Yeah, no, thank you very much, Ravi.
Oh, so I see Maddie's question and Ali's as well. So does Zosyn interact with 1,3-beta-glucan? And are there any other medications that we should be worried about? So I initially had thought too that beta-lactams, such as Zosyn, interacts with 1,3-beta-glucan. But after digging a little bit more into the literature, that's almost a misnomer. So it's not been associated with increased 1,3-beta-glucan. It's more so specific infections. So it's been seen in the literature that if you're infected with strep species and or some gram-negative infections such as Pseudomonas in the bloodstream, then that can lead to false elevations of 1,3-beta-glucan. In terms of other medications, so IVIG, albumin, coagulation factors have been associated with false elevations. Some anti-neoplastic agents. There were that I did not see a consensus in the literature in terms of any other classes that we should be worried about, but those were the ones that I did see a consensus on. So Megan's question, so do we complete MALDI on all sites at UW, and Canada does not typically need to go on special media to grow, right? And yes, that is true. So when I had shown the chrome auger, Canada, that basically is a very normal medium which has specific enzymes which help to delineate between different Canada species. And we do run MALDI on all of the cultures here at UW, I believe.